Lisa Choo. And then, so I'm gonna ask you some questions. So to begin, could you like tell me more about yourself first?
Um, I mean, I come from Singapore and I studied in Singapore for most of my life, up until pre-college or pre-university. And at that point in time, I was trying to figure out what I want to study in college. And psychology was one of the options. I was kind of a little bit more of a science student. So I think I was looking more into sort of doing biological sciences, or medicine, and psychology was one of the options. So when I did my college applications, that was sort of what I kind of focused on. Didn't really have a lot of people to talk to at that time. I must say, maybe not so much in other parts of the world, but in Singapore, there were hardly any psychologists um, or people who had studied psychology at that time. So it's not like I had a lot of chance to talk to people. But I just kind of thought I'll just wing it. Sounded interesting, study of the mind. And I just thought, oh, okay, I mean, that's something sciencey related, but it's still a little bit different. So that's kind of how I suppose I fell into psychology. Um, because it was very less, not very well known. There was only one university, which is the National University of Singapore, that that ran a psychology program. It was under the arts faculty though. So I only had one option in Singapore, and it was sort of under the arts faculty, which I guess I had never really been in an arts-based faculty before college. So I thought, okay, I will apply overseas and then see what comes up lah. So I had more options overseas, and so that's why I left Singapore. And I went to
To
Australia.
begin, oh yeah, I know. To begin, could you walk us through your journey in clinical psychology and what initially drew you to this field and how your focus has evolved over the years?
Okay, okay. So in college or my undergraduate degree, so I eventually went to Australia. I opted to do a Bachelor of Science in Psychology. And it was a 4-year direct honors program that I signed up for. And it's quite a broad-based degree. So it really introduced me to um, quite the A to Z, I suppose, of what psychology is all about. And I think more importantly, how psychology can be put into practice in daily life or real life. I think that was more that. It wasn't just about the study of the mind. It wasn't you know, I I very quickly learned, which was really nice, that this is not like a sociology course or a philosophy course where, I just study and understand theories. It was really a very practical or very application based. So I quite like that. And it kind of offered as a broad-based degree, offered me sort of a wide range of possible pictures of where and how I could put psychology into practice by way of like a job, in terms of employment at the end. So of course I have like over the course of the 4 years, I had like preferences. I quite like certain modules that I studied over others. I mean, I think probably because of my background in science, I guess I was a lot more interested in the sciences aspects. And through the course, it allowed me to kind of also learn about like, do I just want to use the degree to and the knowledge base that I gain from the degree to benefit whatever job I get? Or do I actually want to be a psychologist? And if I wanted to be a psychologist, what type of psychologist I would like to be? And then that meant that I needed to continue my education. Um, because I'm considered an overseas student in Australia, so I did take a break a couple of years, and I returned to Singapore after I completed my degree, and I didn't continue on to do my postgraduate immediately. So I came back and I worked in several settings, or I was exposed to several settings, and not all of which I worked in. So when I came back with my psychology degree, it was limited in the sense that the field is still very new in Singapore. So there were jobs that were looking for psychologists, but would offer OJT, so on-job training, because in theory, I'm not fully trained to be a psychologist with just a degree, a basic degree, even though it's an honors degree. So I kind of dabbled a little bit just for a couple of months into industrial organizational psychology, so like more consulting, business consulting. So um, um, at that time, I was doing some work at Bain Consulting, so more corporate type work. I know that I could have gone into teaching and maybe explore educational psychology, but I thought I would just park that aside for now. At that point in time, I thought, okay, I'll think about it. I joined the Singapore Armed Forces, which is our Singapore um, Army, Air Force. The Armed Forces covers the Army, Air Force, and the Navy. So it's a ministry. It's one of the ministries in the Ministry of Defense, like basically, as a counselor, mainly to service to support servicemen who had, mental health issues or are just, struggling to cope with and adjust um to army life, basically. So I did that for a year and I really enjoyed that. It kind of triggered off this idea that, hey, actually maybe health was what I wanted to go into. And then after a year, I had a job offer at the Institute of Mental Health. Singapore's not very big, as you know, and so we have just one major center of for mental health conditions. And in that outpatient and inpatient hospital or institute would be basically where I guess all the persons living in Singapore who have from mild to severe mental health conditions would be at. So I left the armed forces and I went to the Institute of Mental Health and I worked there for maybe 7 years or so before I stopped to do my sabbatical, aka my postgraduate. And I went back to Australia to do my postgraduate. So it really was those 7 years or so in the Institute of Mental Health that kind of sealed clinical psychology as my chosen field.
So you've worked in both Singapore and Australia for over 20
Yes.
years. What gaps and differences have you noticed between these two different cultures? And what
Oh, okay,
significant
okay,
knowledge?
okay. The reason why I laugh is because um there's so many differences. I don't know where to start to answer your question. Okay, the all the differences are primarily because I think Singapore at every point in time comparatively is still a younger practicing field of psychology than Australia. I think Australia truly, truly is probably more on par with international levels like the main, basically Europe, US, and Australia. They're all definitely on par. At that point in time, I would like to believe the gap has closed a little bit, but at that point in time, we're talking maybe about a 10-year gap. So in terms of what you might ask, like in terms of research, definitely in terms of expertise in practice, not just of the various types of psychology, but even within, say, for example, within clinical psychology, in terms of um, the standards of practice, um, for individual disorder types, for example. So, if we talked about treating depression, we don't have a national center for depression or depression studies like they do in these other countries, like, in the US. We didn't have at that point in time a very consolidated sort of like healthcare system like they would have in the US or, like the NHS in the UK, or even in Australia. So I think those gaps or those differences were very stark from the beginning. And right off the bat, the exposure was exponential. The learning exposure was exponential for me, not just in university, but even like outside of university. So like I would tell people that like, it's quite cool like when I go to lectures and I'm lectured by the professor X who truly is when when I do my lit review, when I just do a simple Google, like he really is truly like one of the big names in that field of psychology. And I'm just like, oh wow, wowzers, I'm actually he is my professor who's marking my assignments, that sort of thing. And I found that I thought that was very awesome. That was very cool. And then because in general, there's just so many people, the country's so much bigger and there's so many expert psychologists in practice in and around the country in the greater area. There were again infinite opportunities to be participating in like local conferences, even just what we used to call in Australia like pub talks. So, in Australia we call it pubs, right, as opposed to bars. So, of course, on the weekend, everybody's, standard, way to kind of downtime from the week's labor is like to go to a pub. And every single week, Thursday, Friday onwards, there will be these pub talks. There will be these, a talk about somebody on by somebody on like depression or anxiety or eating disorder, and it'll be held at the pub. So come and get a drink and then listen to a talk and niblets, and then you got a chance to mingle with others who are practicing psychologists. So it's very, very cool, but very fun as well. Um, because it was so much more ahead than Singapore, I think I really learned very fast and a lot. So, not just about the various disorder types, but also about just the way in which psychologists carry themselves and how we should be practicing. I think it was very much that. And it wasn't so much the vicarious learning, like it was really learning directly from these movers and shakers, I think if I were to call it colloquially. Then when I came back to Singapore, when I talk about vicarious learning, there's nothing wrong with that. But, the only persons at that time, especially that I could really learn from or continue to be um, learning from, right, was actually like my seniors who themselves had the same kind of overseas exposure that I had. So I wouldn't get to learn from the big wigs, but I'll get to learn from seniors who learned from the big wigs, um, which was fine. But I think that it's not exactly the same lah. In terms of like the types of like mental health conditions, I think because with the undergraduate level, I think there was a lot more general exposure, but the moment I did my postgraduate, I had already selected specifically that I was going to study a clinical master's. Um, in Australia at that time, um, the system in Australia, I think is a little bit different from the rest of maybe, let's say, the UK or the US. But in Australia, or for psychology anyway, it is the master's is not an intermediate step to the PhD. It is a slightly different track, simply because it's practicum based. So for the field, I need to sign in on a practicum based postgraduate master's in order to get my registration. So that's the other thing. If I was very serious about being a practicing psychologist, I would need to be registered. That also is the fundamental difference between Singapore and Australia. Even then, which was many, many years ago, there was already very early on a requirement to be registered in order to practice psychology, but that wasn't the case for a long, long time in Singapore. That's only been the case maybe, say, in the last, as as recent as maybe in the last 5 to 7 years only. Truly, truly, which is very sad, but we're getting there. Which really meant that for a long, long time, there's a lot of people in Singapore that are practicing who may or may not be legitimate. I don't know how to call it that, but yeah. So we didn't have that governance initially, and that to me is a very important difference, given that I had the benefit of being trained overseas. In terms of like my work, the exposure that I got in Australia, as well as in Singapore, I think it kind of changed and it evolved over the years. In school, I did quite a lot of child and adolescent work. So I was trained in a lot of child and adolescent work. And then when I returned to work after my postgraduate studies, I was doing a little bit more on the opposite end of the age spectrum. I was doing quite a lot more of the older age population. So I was doing a little bit more like dementia work for a couple of years, but then I eventually went back to early adult and child and adolescent work, specifically adolescent and early adult. So the kinds of conditions that I would kind of work a lot with would be like anxiety, depression, eating disorders. You do get the occasional sort of very severe mental health conditions like, schizophrenia or psychosis or psychotic disorders. But, in terms of, and OCD, obsessive compulsive disorder. So they are all mental health conditions lah. So it was very useful to kind of be assured that, I had the right training for the types of conditions that I would be seeing at work.
Um, what type what types of mental health conditions did you most frequently work within your hospital or in community practice setting?
Um, I mean, if you only gave me a one choice answer, I guess I would
Like
say,
one or two.
yeah, then definitely anxiety and depression for sure. I mean, this is also, it's not a very big surprise because if you look at the prevalence and incidence rates, for mental health conditions specifically, um, anxiety, depression, even if you look at the World Health Organization statistics, right? I mean, these are the most sort of frequently diagnosed mental health conditions. So definitely anxiety, depression.
Um, why do you think that? Why do you think there's like so much like depression and anxiety? Anxious.
Um, I guess, I mean, over the years, I think it's kind of great that we actually did, um, in Singapore, we actually did manage to get our act together, and the standards in psychology and psychology practice definitely climbed. And we're also sort of we do a lot more research of our own now, which I think is very important because for the longest time we were just relying on international research, but a lot of it was not really, we wondered if it was truly applicable to the Singapore population. So it's very good that, my seniors and just, the slow but steady growing movers and shakers in Singapore would start to kind of do a lot more research. The interesting thing about it is that there really isn't a whole big difference in the results for local data, local Singaporean landscape picture compared to the rest of the world. Um, Now that we've done our own research with our own population and we're wondering if maybe we're not as depressed as the Americans or, or the Australians, but actually it's plus minus thereabouts the same. Interestingly, the incidence and prevalence rates. So it can't be, I don't think it's culture specific, I guess is what my answer to your question is. Like, why might there be, what is it like and why anxiety, depression? So I think it's still, and also anxiety, depression. So not so much the culture or race, but I guess it's definitely more like the environment. I have to say, like, and that's the biggest, um the 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 hardest, the reason why it's hard to answer your question is mainly because we can say that the climate and the environment has changed in terms of the pressures, that following generations are facing that are different from the generations of yours and my great 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 grandparents. But then at the same time, I mean, it's hard to say absolutely for sure because in those old times, we wouldn't know about anxiety or depression or ADHD or autism or eating disorders or anything like that. So even if it were prevalent, we wouldn't even know that that were the case, right? As long as there's any reason why you can't sort of cope, say in school or at work, you'll just be rendered, sort of labeled like you just dropped out of school and or you're unemployed. There wouldn't really be much of this sort of fine comb distinctions to why that might be the case. So, but having said that, I think it really is more environment. The expectations have risen of people, and of course, I know this is probably a standard paragraph in any essay any school going teen will have to park in, be it for English or literature or for any other reason. But I think definitely with social media, with technology and AI, it's really caused a lot of rapid changes, and whether or not the human mind can kind of cope with all of those changes, and if so, how does the human mind cope with? I think there are a lot of individual differences, and that probably might have precipitated, for some people, um, might explain for some of, of these mental health presentations.
So I'm currently working on a research paper about bipolar disorder,
Hmm.
and I'm exploring like the biological aspects of this disorder and like the challenges in the diagnosis and treatment, as well as like the social stigma surrounding it. Like given your like extensive clinical experience as well as your work in diverse fields such as like hospital and like, the diverse fields,
Mm-mm-mm.
how has your professional journey shaped the way you understand and approach complex mood disorders like bipolar disorder?
How has it shaped? I mean, okay, so it's quite interesting. I do have, okay, so coming from the perspective from two perspectives. One is that I happen to have a a, f- a school friend from long time ago, who has bipolar disorder. Um, at that time, earlier on, of course, I didn't know then that it was bipolar disorder. Before all my, as you pointed out, before all my professional journey started, I just kind of knew that this friend of mine was always like that. Sometimes he'll be like super happy, and sometimes he'll disappear for a couple of days, might skip school for a couple of days, and would kind of speak a particular way. And then, but we always sort of said like, oh, he'll be all right after a couple of days. He'll crawl out of from under his shell. And I think it really, I mean, obviously it was really only after I began my professional psychology journey, did I then, looking back, realize, ah, okay, I get it now. It's all making sense now. Why he was like that, during certain times, and why he was different during other times. So, I think I immediately I immediately felt guilty, because my friends and I, our group of friends, we definitely made a lot of assumptions that were, on hindsight, all wrong. We kind of thought that he was an odd personality. We used to tease him about it. We used to say things like, you're like an alien from Mars. No one else does this, no one else sort of like, and we used to actually get really upset whenever we make plans to hang out as a group, and he would just cop out. As in, he wouldn't just cop out, like cancel out. He just would just disappear from the face of the earth, and we wouldn't even know what happened to him. He wouldn't have told us. He basically just didn't turn up, and some of us would get really quite upset and say, you don't value our friendships. And there were some people in our group that really, I guess, distanced from him. By nature, I might, I mean, I don't, I mean, I'm okay, but I definitely got upset during all those times as well, but I didn't sort of give up on the friendship, and I just kind of left it. Of course, we distanced ourselves. So only after that, then I realized, aha, now I think I know what's wrong. And then when we kind of caught up afterwards, like after I am a little bit more educated, and then he, he knew that I studied psychology. Maybe that's why he felt comfortable to kind of talk to me. And then he says, do you remember, we were reminiscing about the past, and then he's just like, oh, do you remember what, last time I used to be like that, like that. I'm still like that now, Then I said, oh yeah, I can imagine. Um, and then he says, but you study psychology, that there's something wrong with me, right? You mean you can't guess? And and he grinned, and then I said, well, now that have a little bit more training, yeah, maybe. Then he said, so what's your guess? What's your guess? So I said, no, that's so rude to guess. And this is not a professional setting. He said, come on, come on. So we had a little bit of fun about it and a bit of a laugh and a joke about it. But he says, I don't know if that's on your mind right now, but I have been diagnosed with bipolar disorder. And I said, yes, it is on my mind. He says, yeah, I mean, I didn't really feel like it was necessary to tell all of you, tell the gang. Do you know that I was even on medication? So I said, no. But yeah, I mean, I do know that persons with bipolar disorder oftentimes do need to be on medication. So in that sense, I'm not surprised. And he says, like, then we talk about some of the other friends, I don't think so and so understand. I guess maybe I pissed them off too much, was, quote unquote, what he said to me. And he says, how come you're not like pissed off like them? And I said, well, partly because, I don't, my personality, I don't break up with my friends really. I just may not talk as much with them, but I don't break up with them. And the other thing I said, well, as you pointed out, as you are smart enough to point out that, now that I have a little bit of training, you know, I I have a different mindset change. So I think this is the point I want to make to you. How has my professional journey shaped the way that I understand? I think it's not just knowledge in understanding of the knowledge, but I think it's changed the way that I approach people. Given that I'm now a little bit more aware of the human mind and the differences, the individual differences of the human mind, I think it sort of made me more not so quick to make assumptions, not quick to judge, um, and certainly a whole basket full of empathy.
How does bipolar disorder typically present in patients across like different age groups?
How does bipolar present
Like,
diff
how
uh,
old do you find out that you have like bipolar disorder? And like how like if you're younger, like are like the symptoms like are the manic and depressive episodes
mhm.
just as bad or like do they get worse over time?
Um, okay. I mean, like the average age of onset for a diagnosis of bipolar disorder is usually in the late teens, uh, and into, I guess, early adulthood, usually. Meaning that it is also quite rare to see like kids, like 12-year-olds or 11-year-olds kind of have bipolar disorder, per se, or to be diagnosed, or rather with bipolar disorder. So it could very well be that they might be diagnosed with other mental health conditions. Although like I think some people or some, that there would be some write-ups that will say like, it can even present much earlier on in age. Like, so yes, maybe even in pre-teens, I suppose. But I suspect that it is misdiagnosed. A is less common, like I said, but I think it could also be kind of like less misdiagnosed, as in, they might sort of be when they go and seek help, the help seeking might be more focused on other behavioral issues, other mood issues, more that sort of like behavior pattern presentation, which would then complicate things because then we wonder whether this person is, like depressed, which does happen a lot earlier on in earlier childhood, or whether it is just some conduct disorder or some other more kid type conditions, mental health conditions, and it might sort of be missed. So typically, I think it's kind of diagnosed a little bit later on, but still within the early adolescent or teenage years. For sure. It is kind of a lot, therefore, on the opposite end, a lot less frequent for somebody who's like a grandma and would suddenly be diagnosed with bipolar. If anybody had bipolar, it would come out earlier on, basically, is the easier way to kind of understand it, lah. Um, I think the complication is trying to figure out, the diagnostic complication is trying to figure out how significant one. So, as you might know, bipolar is either very manic symptoms or depressive symptoms. And sometimes it's hard to kind of pick out, especially if it's not reported. So, as you know, psychiatry and psychology is not, it's not like a little sort of urine test that you take or a blood test that you take and you have bipolar, or you have schizophrenia or something like that. A lot of it relies heavily on reports, self-reports by the person, as well as reports by people around, so caregivers, family members, relatives, friends, etc. And sometimes it can be missed, especially if you have more predominantly depressive symptoms and only like an occasional manic symptoms. Some people are, the opposite. They feel that like, they might be more manic symptoms but hardly any depressive symptoms. And so you can't really tell for sure, for sure, for sure. Of course, those who are very sort of frequent up and downers is quite much more obvious. So it was just this one friend that I remember that I'm sharing with you. And of course, with that sort of that knowledge, the non-judgmental, the greater understanding, and the whole bucket full of empathy, right? I also have for like what I call famous people with bipolar, diagnosed with bipolar. So I think now with the lowered, I wouldn't say zero, but lowered stigmatization across the world with mental health conditions, thankfully there are good advocates. There are real famous people advocates of mental health conditions, including especially um what do you call that, like bipolar disorder lah. So that's been very helpful, and it really allows me and maybe other people to have that aha moment, like the now I know why this person, that person is like that, or presents like that, um, yeah, etc., etc. I mean, I think there's been quite a lot of like famous people with bipolar. Um, yeah. In my time, maybe not Lillian, not your time, but my time, Mariah Carey, I think, has got bipolar. Maybe your time is more, I don't know, Selena Gomez. Your time, famous people. Like, yeah, I mean, there's quite a number of famous people. But historically, I think I read my history books before, like Winston Churchill had like bipolar as well, and the Kardashians, what's his name? Kanye West has got bipolar. I think that one is quite obvious because I think he's in many sort of public settings, some of that behavior, that bipolar behavior has kind of come out, or the symptoms have come out as well. So yeah, so it's really allowed me to be a bit more, to be a bit kinder, I guess, in short, and not be so quick to
Um,
judge. Mm.
mhm. In your point of view, what is the most effective treatment or approach for patients affected by this
This condition in
uh
particular?
yeah, like how crucial is it to have like long-term like therapeutic continuity for like patients, like continuous, like what would happen if they just stop taking the medication or like stop going to therapy?
Okay. So for bipolar, to answer your okay, so if I am very simplistic, then definitely my straight answer to you is yes, but to varying degrees. So yes to what? Yes to treatment. I think it is to varying degrees because there are different types of bipolar and related disorders. So depending on the type of bipolar disorder that you're diagnosed with would determine the length of treatment that's required. Okay, so like I think there's bipolar 1, there's bipolar 2. Bipolar 2 is like milder, like people don't really have like a manic disorder or episode before. Then there's like, I think, I don't know, I can't remember now, like, without looking at my textbook, but cyclothymia, where they have cycles, like, and that does happen sometimes in the younger people, the teenagers, but they're all like very not so severe symptoms, right? And then, of course, sometimes it can be confused by just simply, um, what do you call that? Like, um, it can present these mood fluctuations that we are familiar with in bipolar can present from other types of health conditions. That's also a possibility, and or drug use. So in some of these other conditions, right, like if you're not taking drugs anymore, then you're not going to have these symptoms. Then you don't really need to keep having treatment because it was kind of triggered off by something else that you did or something else that you took per se. But with the previous ones, those are that are more sort of more definite mental health diagnoses, then yes, the treatment is a longer term rather than shorter term treatment, I think is always advocated. The treatment modality, if you ask me for sure, for bipolar, I think definitely drugs or medication is definitely warranted, I feel. And or, and then, non-medication um, interventions as well, maybe a little bit later on. But definitely medications. With bipolar disorder, if you have a diagnosis with bipolar disorder, unfortunately, other than the little ones I said at the end part, like it could be triggered off by, specific drug abuse or whatever it is. Other than those ones, all the other ones above it, I think bipolar usually, it's very awful a diagnosis to get compared to other mental health conditions because I think um usually they recommend ongoing treatment for life. Even when you feel better, they will say like take it because there is a vulnerability, basically, like you the fluctuations, right? And so you need the medication to kind of help stabilize and to prevent any more of those fluctuations. But of course, always talk about like how like at the start when the fluctuations are really great. I mean, when you're in a highly manic state, you really don't know what you're doing. You can want to aim to do all kinds of things, much of it which is dangerous. And so sometimes like a mandatory like at hospital admission might be part of the treatment, uh, you know. But definitely medication lah. For bipolar disorder, definitely more medication, primarily first, and then sure, then later on maybe some therapy or talk therapy as you call it, to kind of really more just teaching the person to help cope with the bipolar and to kind of understand the consequences of it and how to manage life with bipolar.
Given your experience in mental health education, what do you think institutions and workplaces can do to develop the system to support individuals with bipolar disorder?
Ah. It is challenging because for several reasons. Number one, I don't actually have the statistics for bipolar disorder, but I suppose it's still not the most commonly occurring condition.
Yeah, definitely not.
Yeah, correct. So to kind of launch on a full campaign to educate or psychoeducate workplaces specifically about bipolar disorder, I think that is, um, like
Right.
whether or not it's the most efficient and the most critical thing to kind of do. I mean, it's different if I guess if you're kind of, but for sure, I agree. I feel that like um all workplaces should be exposed or have a good support system for general mental health conditions, general mental health. Not just physical health, um, but mental health. Yeah, for sure. Um,
Do you think like having like mental health conditions in general, like in Singapore, is it like stigmatized? Do you think people judge, like as you said, like your high school friends, they're judging like
mm,
they didn't
yeah.
understand.
Um, um, yes, yes. It is better, but it's still very stigmatizing. Better as in there is greater awareness. There are a lot more people who are less bothered about other people knowing. There are also more formal there is formal systemic change. Like for example, in schools and in some but not all workplaces where mental health awareness talks um, are mandatory, not just for, say, the students or the staff, if it is school or workplaces, but also for teachers, for school leaders, as well as for like middle managers, bosses, leaders. Like there's a lot more. I'm just speaking for Singapore, okay, because I would imagine since we are so far behind, other parts of the world just laugh at us because they've been doing this for ages already. But like even when I say formal systems and setup will be things like, nowadays, which was unheard of in the early days, you can even um you in the early days you would not dare to declare a mental health condition because it might affect your insurance claims. But nowadays, insurance policies that people buy for themselves or for their family actually cover mental health conditions. So, like if you were to then be diagnosed with, depression or depressed mood, you can actually get medical claims back from it. You can actually claim from your insurance from it, which was definitely unheard of in before years ago. But now, so I think structurally and systemically, it's definitely a work in progress. It's definitely getting better, but the stigma is still there, especially when you talk about like generations. So if you talk about like today, 2025, right? If you look at the subset of the population of the elderly, the grandmas and the grandpas who actually were living more in the era where all of this was not in place, they still definitely carry along with that strong stigma. Not just, yeah, I mean, not just for more hardcore mental health conditions like anxiety, depression, but even, it's like even just kind of convincing, an elderly person to possibly go get himself checked out for possible dementia. That's so stigmatizing. he would not want to go. He would not want to admit that he's having some memory difficulties or that lapses here and there, stuff like that. So it's very, very hard. But there's more in place lah. Yeah.
What idea gives you hope or optimism about the future of mental health care for those experiencing BPD or just any sort of mental disorders?
Okay, so just specific to not just specific to BPD lah, but just maybe mental health. Okay. Two responses to that. Anecdotally, and anecdotally, there are more and more people, Singaporeans, there are more and more Singaporeans who are interested in there are more and more Singaporeans who are interested in studying psychology. So that's very heartening to see. Like there are more and more people interested. And maybe not everybody will end up being a psychologist in healthcare, but if more and more people study psychology, the likelihood is definitely has increased, right? So that's one thing. And the second thing is what I mentioned a little bit earlier. I think some of those professional and formal and structural changes that are already seem to be evolving, right? Like with insurance policies. So it's not just insurance, it's even at the workplace. So it's not insurance, individual insurance, health insurance per se, but like many places that you work. So if you look at workplaces, right? At places that you work, that they do have schemes that they've adopted maybe from the West. Like, it's not uncommon in Singapore. I also cannot believe it. Stuffy small Singapore, like it's not uncommon for workplaces to have like mental health days, which is outside of your annual leave, where you're just allowed to just take a day off and you can just label it as a mental health day just because. Like you just needed it and you don't have no questions asked. It's not gonna come out of your regular leave entitlement and no one's gonna say anything. You cannot be, marked down for it. So and even then many bigger organizations actually offer like workplace counseling. Workplace counseling meaning that, I mean, you don't have to have it at work, but they sponsor is not the right word. They cover staff to get, X number of counseling sessions if they felt they needed to for whatever. Again, no questions asked. In schools, definitely there are a lot more flexible with, in a very similar way lah. A lot of schools, I'm sure standard, right? If you don't go to school because you're sick, you have to kind of provide a medical script, usually, right? And that's still the case. But, there's also an X number of days, plus minus, just sort of a couple of days in the whole school year that you're allowed to kind of just take off. And at most, you just need like a short note from your parent, which was not heard of last time. Yeah.
So there have been a lot of changes recently.
I think so. Good changes.
Thank you. That's like the end of the question.
Oh, was it? Yay.
Yeah.
Okay, so is this like a okay, wait.